A case of hepatocellular carcinoma associated with glycogen storage disease type 1b. We have nothing to declare for this study. The case was 36 years old woman. She was diagnosed as glycogen storage disease type 1b at birth and had a history of surgery for hepatocellular adenoma at the age of 20. She was referred to our department because liver dysfunction was observed when she gave birth at the age of 30, and she has been followed up regularly. The abdomen was soft and non-tender. However, her liver could be palpated 15 cm below the right costal margin. In 2021, abdominal ultrasonography and CT showed a 15 mm mass in segment 6. Laboratory findings showed no liver dysfunction. Tumor markers were within normal range. Her renal function deteriorated and she underwent hemodialysis. Plain CT revealed 15 mm hypertension area, and on dynamic examination, the tumor showed no enhanced area in each phase. UV-MRI revealed intense enhancing tumor or arterial phase, although the tumor showed ice intensity on portal and delayed phase. Washout finding was not identified on hepatobiliary phase and diffusion waste image, but showed a high intensity on tissue waste image. It was difficult to distinguish HCA from HCC. Abdominal ultrasonography revealed a 15 mm size mass with hypoechoic peripheral zone and mosaic pattern of internal echo. Contrast-enhanced ultrasonography revealed hypervascular nodule in the early vascular phase and defect in the portal and cupped phase. Based on these examinations, the tumor was preliminarily identified as hepatocellular carcinoma, and we performed ultrasonography-guided radiofrequency ablation. Pathological examination showed that the tumor was hepatocellular carcinoma. After 2 years of follow-up, enhanced CT showed no recurrence of tumor and no new ones have been seen. Hepatocellular adenoma is one of the important complications of glycogen storage disease type 1. GSD1 patients manifest a long-term risk of HCA-HCC that develops in 75% of GSD1 patients over 25 years old. In GSD1, HCA can transform to HCC, and rates of transformation into HCC have been reported approximately as being up to 10%. GSD1b leads to abnormal glucose metabolism and glycogen accumulation induced by the deficiency of G6PD. G6PD deficiency leads to hepatic autophagy impairment that can contribute to hepatocarcinogenesis. Liver transplantation may be the only surgical option for GSD1 patients who have multiple HCS-HCCs. However, liver transplantation from brain dead donor occurs rarely in Japan. RFA, surgical resection, and transcatheter arterial chemoembolization of HCC are suggested as effective intermediate therapy for prevention of HCC until liver transplantation. Hepatic adenoma in GSD1 is considered to be a premalignant lesion, as it has been reported that some patients with HCA developed HCC later. It is imperative that all GSD1 patients be closely followed by the use of ultrasonography or CT scan. Thank you for your attention.